Which camera? And good morning, everyone, or good afternoon for our European colleagues. As you can tell, PerfWeb has been altering our times to do in the morning and then also to do in the afternoon so that people from around the world can tune in and not have to be up in the middle of the night, which we've had some do. So hopefully we have some European colleagues there today. Welcome to PerfWeb 44. I think our numbers are back on track. And this is Tammy Sparacino's Journal Club number 7. The title for today is going to be Obesity, a Critical Risk Factor in the COVID-19 Pandemic. But before we get started, as you well know, I have to go through the housekeeping notes. And by the way, it's good to be back.
Welcome back.
Thank you. I appreciate that very much. So our sponsors, LivaNova and Siemens, and HET, Houston Extracorporeal Technologies. Please check them all out. And if you are looking to relocate to Houston, or you are already in Houston and looking for a great place in which to practice your profession with a group that is, I think, well recognized as the best group ever, please call HET. You can find us on the website, het.us, and give us a call. Also, make sure you click on LivaNova and Siemens and look at the things that they have. Both of these companies are very, very, very involved in education. They're strong supporters of us, and we really do need you to check them out. Social media, Facebook, Twitter, YouTube, LinkedIn. You need to like us, follow us, share us. Make sure you subscribe to our YouTube channel. Give us the thumbs up. Don't give us thumbs down. That's not allowed. And make sure that you click the bell notification button so that you can find out if we're doing something sort of out of order that may not even be on the website, because that is going to be coming. We are really revamping the 2021 programming. I think you guys are going to be really amazed at what we've taken that we've learned through 2019 and 2020 through the pandemic and all of that. And we're going to be doing something even more interesting and more interactive and more fun as we move forward. Let's see, websites and contact info. So you need to make sure that you go to perfweb.us. That is where we have our schedule. And then also go to, and you can link from there to perfusioneducation.com. If you go to perfusioneducation.com, that is where our library is housed. So both websites are interconnected, but they each serve a different purpose. To understand the schedule, perfweb.us. To understand, to go to our library, to become a member, which is free. Or if you want to earn CEUs, we have unlimited plans. We have pay-as-you-go plans, very affordable. I think our price is about $15 per CEU, plus or minus. You can go ahead and go there and get all of the CEUs that you need for your certification. And hopefully, in time, we will be able to open back up again to live programming. And when I say live program, I mean in-person conferences, as was the case in the old days. I'm hoping that happens. I'm a little bit concerned that it will happen, but, you know, if it does, when it does, we are going to definitely be one of the first, if not the first, to host an event. So be looking for that as we continue to evolve our understanding of COVID-19 and the restrictions are relaxed and we're not all afraid a vaccine exists. We're not all afraid of getting it at that point in time. Our call-in number, when you see this symbol, please pick up your phone, dial that number, someone will answer it, and then you would be able to be live on the air, and you can ask your question or make your comment or whatever the case may be. I want to quickly go over our new app. I have it right here. I would really like for you guys, and here it is right here. You can see it. There it is, just like on the screen that you see there. And the app is a perfusion ECMO specialist, critical care nurse, really critical care doc app. It's broken down into various sections. You have perfusion, you have ECMO, you have hemodynamics, you have clinical calculators, you have IV calculators, and you have conversions. Now, if you buy this app, which is only $2.99, it's very affordable, it comes with all of the updates. So as we continue to update and evolve this app, you would, of course, be able to just download those updates as they become available. So I would get it while it's $2.99 because I don't believe the price is ever going to actually go down. I do think that it will eventually go up. You can get it on the App Store. In fact, if you go to our website on MediWeb and click on the app, you can see there, you can just take use your QR reader, and that'll take you right to it, Google Play or the App Store if you're using Android or you're using iOS, whatever the case may be. So please don't hesitate to do that. I think the app has tremendous utility. It was very laborious to create. It's highly validated, and I think that you would really enjoy it. So check it out and give us a testimony or a rating. Make sure you rate it, but buy it and use it. Okay, I mean that's really all I can tell you. It has Perfusion Quick Calcs on there. If you're doing a case, you put in the basic information, and it just spits out all of the information you need to do your case. And if you want to know what your SVR is, it'll give it to you right away. If you want to know what your oxygen transfer rate is, you're concerned about your oxygenator, it'll give you that right away. You just put the information in, click a button, and boom, there you go, it's done. Okay, so in the meantime, let's go ahead and start introducing our esteemed faculty, if we may. As you can see here in our split screen, immediately to my right is the creator of the Tammy Sparacino Journal Club, Tammy Sparacino herself, here in the actual flesh. Look, my hand's crossing over into your section there. And then in Orlando, Florida, is my good friend and stalwart supporter and participant and overall just fantastic guy, clinically incredibly competent and smart as could be, much smarter than me, John Ingram. Our last program, John and I were in the same room together overlooking this beautiful beach. The biggest mistake we made was being in the same room together because I know y'all had feedback. There were all kinds of technical difficulties at the time associated with that. So we learned a little bit of a lesson, but nevertheless, it was a lot of fun, and you did an outstanding job. We did a horrible job. Actually, I thought we should have just cut ourselves off and let you just do the program yourself. I think it would have been a much better program. Or John and I should have sat next to each other.
I think y'all should have just been like this.
We should have been. I think that would have been a much better choice. So welcome, John, as usual. Thank you so much for being here. Tammy, thank you for being here. I think I gave the title, I'll just say it one more time, Obesity, a critical risk factor in the COVID-19 pandemic. So we're going to review that quickly, and then we're going to talk about basically, I think, obesity as an independent risk factor for just about everything.
Correct.
And how maybe we as perfusionists need to better appreciate what really is obesity. We think of obesity as, blah, but it's not. I read this article and I was like, wow, that's pretty impressive.
Yeah, and not just in our clinical practice, but just as a society and what's going on with where we're headed with this problem and what a great problem it is medically, and it's also debilitating socially. I mean, there's all kinds of things that we could really talk, on and on about this.
But one of the things that I got out of this article, and I hope all of you will read this article. I think there's a link to it.
Article.
No, this is a great article. But how many times have you heard me say about these patients with bellies? They may not be that big everywhere, but they got the belly, and what that's doing to their residual lung volume and basically their thoracic compliance. And I found that in here, and I was like, well, I'll be doggone. I've been saying that for about 20 years now. That's the alarm over there. Just hit 2006.
I think we lost John's feed, though.
Oh, we lost John's feed.
They're working on it. They're working on it.
Oh, okay.
John will be back soon.
Okay, good. So anyway, with that said, do you want to go ahead and get started with your slides?
Yeah.
And then we'll do the review, which we have to do for no credit, and then we'll start with the actual program.
Absolutely. Okay. So as Joe mentioned, this article Is obesity a critical risk factor in COVID-19 pandemic? It was published in Clinical Obesity, let's see, in August of 2020, so it's very recent. It was put together by a group of individuals at Manchester University for the National Health Institute over there. And it's, well, I guess the article will kind of speak for itself as we go, but it's a really fantastic article, highly referenced, 140-something references. I mean, they really did a great review.
That's a lot.
Okay, so this is by C. Kwok. Please forgive me if I'm pronouncing that incorrectly, and colleagues. All right, let's just talk about the summary a little bit. So I think we're all aware that obesity is an emerging problem, as just generally speaking, for health reasons worldwide. But we're specifically, this article is looking at this as an emerging independent risk factor for susceptibility to and severity of COVID-19. They found that it's caused by severe acute respiratory syndrome. Previous and viral pandemics have shown obesity, particularly severe obesity, which is BMI greater than 40, is associated with increased risk of hospitalization, critical care admissions, and fatalities. This is a narrative review. They examined emerging evidence of the influence of obesity specifically on COVID-19, the challenges of the clinical management for pulmonary, endocrine, and immune dysfunctions in these individuals, and they wanted to also identify potential areas for further research. They concluded with the recommendation that people with severe obesity be deemed a vulnerable group for COVID-19 regardless of age, that clinical trials for different drugs and immunotherapies and vaccinations should be prioritized for these people. Okay, why was this paper published? Well, beyond just talking about COVID-19, which there's lots of research going on about that, obviously, because of what we're all experiencing, I thought it'd be interesting just to look at the numbers of obesity worldwide, because I think that's really why this paper was published. Not the specific problem, but why. 39% of people worldwide are overweight. 13% are obese. As you can probably well imagine, in more developed countries, wealthier countries, the problem's even greater. In the U.S., 32% are overweight, and you might say, oh, that's less. But that's because our obesity rate is much higher. We're 40% obese in the United States. In England, where this study was published, 36% overweight and 29% obese. So obesity is a very prevalent problem for our society. So now during this pandemic, we're seeing special precedence in severity of treatment, severity of symptoms and mortality, and the treatment is much more difficult. All right, what problems were they trying to solve? I'm actually going to read you a direct quote from this because I thought I couldn't put it in better words. They wanted to explore the relationship between excess weight and the response to the infection with COVID-19 and the severity, complications of this disease, discuss clinical and public health strategies for managing the risk to identify research priorities. How did they do it? They did a systemic review and meta-analysis. They talked about two specific meta-analysis that they did. One was of 13 studies, which included 3,027 patients. And this is what the determination from that was. Males, people greater than the age of 65, people that had comorbidities of smoking, hypertension, diabetes, cardiovascular disease, and respiratory disease were the ones at greatest risk for developing complications. Then they did another meta-analysis of 14 studies, And of those 14 studies, obesity was a predictor for mortality.
Independent predictor.
Independent predictor for mortality, correct. This is a graphic that they included in their article, which I thought was just awesome. It's they didn't actually create this. It was created at the National Health Institute over here, but I think what's striking about this is the odds ratio of developing complications with COVID, and you can see they've sized the actual coronavirus that has, you see it in an electron microscope, you know, to represent the odds ratio, and you can see obesity is clearly the largest,
yes,
then lung disease and age, and
that.
Cardiovascular disease. But I thought graphically that was just a
don't go off that slide. It is very telling, but I mean, when you look at it, you see obesity, yes, it is the largest, but age, cardiovascular disease, CVD, and lung disease, when you look at those three, they're smaller than obesity, but not by much. Age looks like the next one,
yes,
but they're all pretty similar. So they seem like they have some pretty significant, and of course, the numbers you see there as well associated with it, from basically from 6.98 to 6 on age to 5.15, but diabetes is right in there. So it really looks like those 1, 2, 3, 4, 5 things carry the overall the major burden, especially if they're in combination.
Well, that's what I was going to say.
Oh, okay,
it's not just being obese. I mean, that alone is substantial. But typically, if you're obese, you're probably going to have these other things as well. Of course, age can be independent from that, but often is not. All right, this article broke it down into, I thought, really great topics of kind of what they were looking at for potential mechanisms that can cause increased severity in obese patients. It's pulmonary function, thrombotic risk, immune function or dysfunction as it may be, the endocrine system and its dysfunction, micronutrients, and then drugs and vaccines. They brought up some really interesting points that often drugs in themselves, if you look at how they're to be prescribed, obese patients aren't necessarily even within the range of how they're telling you how to dose these.
Yes, because there's just too much weight, and they base everything on what is considered the ideal body weight.
That's exactly right.
And so these patients are frequently, I believe, with a whole host of things in the hospital, are very underdosed.
Correct, correct. And we'll talk about some of this in more detail, but let's just continue on with talking about just our review of the article. This was another graphic which goes into what we were talking about, that obesity may be at the center of it, but these are all the problems that are often associated with obesity. You know, you've got impaired pulmonary perfusion, chronic inflammation, and they all kind of can contribute to each other, and so you get this circle of problems, and all centering from obesity.
Yeah, I mean, can you go back to that?
Oh, absolutely.
Let's spend a little bit of time on this, if you don't mind.
Absolutely.
But I mean, these are some really key points I think we need to look at. First of all, the chronic inflammation. You know, with the TNF alpha, the interleukins, the interferons, basically you have all of your pro-inflammatory stuff. Then the respiratory compromise. Again, reduced chest wall lung compliance. It's huge, but look at what it leads right to. It's very difficult to prone these patients if you believe in proning. Now, Dr. Joy Thula, as you well remember, does not truly believe in that, but those that do believe in it. But higher ventilatory pressures required. Again, one leads to the other.
Well, and even just as going from critical care limitations perspective, just getting them properly intubated can be extremely difficult just because they're larger.
How about getting a cannula in their right IJ?
Right.
That you really need, because I am very, I have become very, I used to think and I've changed how I feel about this, or my thoughts on it have evolved from whatever experiences that I've had. I do not like double cannulation technique. I don't like it at all. Both femorals with one higher or lower, fem, right IJ, don't like it. I really think that the versatility and the movability, the managing of the patient for proning and various other things that you have to do. But I also feel like if properly positioned, and that's critical, obviously, if properly positioned, the either Avalon or Crescent catheter provides a much, much better ECMO therapy flow, effective ECMO therapy flow, if you will, less recirculation, easier to manipulate the patient, put them in better positions so that you maximize whatever lung tissue they may have that can contribute and reduce recirculation, all of those factors. I really have gotten to a point of disliking double cannulation technique completely. I think it's a bad idea.
Let me follow up with something that you said, proper positioning. It's also the maintenance of that proper positioning, because, you know, when you're proning or even just cleaning up the patient or trying to maneuver their neck some just to give some relief, you know, for the face that you're side of the face that you're laying on, I think it's you have to maintain that proper positioning. I mean,
absolutely. Well, I think that's where, and this is something else that I've really thought about a lot after this latest episode, where we just saw so many more ECMOs than we had previously seen.
And for longer periods of time, which gives you even more opportunity for malpositioning.
Yes, or for dislodging its positioning. So two things that I'd like to say about that, if I can, and this is for those folks that may be listening who have an ECMO program or want to start an ECMO program, or maybe just don't have a very big ECMO program. You get it positioned, you measure it. I know I talk about this all the time. You'd think that I got paid by them, but I don't. I would highly recommend the transonic elsimeter. I think having a device that can give you accurately and precisely and in a replicatable form, easy to use form, the actual amount of recirculation and intra-oxygenator blood volume for VV ECMO for the recirculation as well. That data immediately, and then being able to follow it so that you know whether or not there is a problem. It's changed. There's a change. Why is there a change? Is it the cannula got positioned differently? Is the patient hypovolemic? Blah, blah, blah. You go through you go through your algorithm and you come up with what the probable answer is, if you will. So, but the one thing I have to say that is so critically important is secure the cannula. Don't put the thing in and at one small little stitch and then just tie it and put a dressing on it. That is not going to work.
Well, and you also need the head, you know, what is that?
The headband.
The headband.
Yes.
That helps secure it. And you also need to not worry too much about trying to clean that dressing and you know, all of those things.
It really needs to be sutured in very securely, and I would say that you will have a much better ECMO treatment experience, and the patient will benefit best by taking the extra time to make sure the cannula is positioned properly. And take a photograph of the cannula position as it's relating to the patient.
Yeah, how the torque and everything.
So that you can later on reference that if you think there's been a change, because the staff changes, we relieve each other. We can't stay there. One person can't stay there for 3 weeks. 3 people can't stay there for 3 weeks. You know, it's going to be more than that. And take a photograph of it and have that photograph available to everybody so that you can see the cannula position and see if there's been any significant change. Recognizing it doesn't necessarily have to be significant for it to make an effect, but that's where the elsimeter comes in. Hey, I'm concerned about this. There's been a change. I'm not sure what the reason for it is. Let's check the position, the recirculation. Let's do it, and you can get that data right away.
Well, especially with proning. You know?
Especially with proning, yes.
Because, you know, you might think, oh, I'm going to pin my lines and we're going to have the patient's head this way and we're not going to move them.
Mm-hmm.
But if you're proning, you're going to move them.
But, you know, Tammy, something as simple as just sitting the patient up at a 45-degree angle,
Right.
especially if they're belly fat holders. They're not necessarily fat everywhere else, but they have that insulin-resistant fat pad that you see, and that, when they're laying flat, pushing up on the diaphragm, reducing your lung capacity, you're going to have higher peak pressures on the vent, your lungs aren't going to fully expand, and you're not taking advantage of any native lung function, which a lot of times with some of these patients, they're big enough, we can't flow enough. We're capturing what, 60%, maybe 70% on a great day of the patient's total cardiac output, especially if they're big and hyperdynamic. So, you know, you have, and then on top of that, having 30% recirculation, you're almost really not doing a lot for them. You have to look at the whole picture, and being able to sit a patient up at 45 degrees without putting them in reverse Trendelenburg, which people do when they're femorally cannulated, and then you get the pooling issue of the blood in the legs in patients who they are suspected as having a hypercoagulable condition, coagulopathic condition, is only going to make that worse.
Yeah.
So, you know, and then you have volume issues, and the legs start to swell, and all of these problems. You want to be able to sit people up. Reverse Trendelenburg and sitting them at 45 degrees are not equal.
Right. Well, and two, you know, you need to pay attention to your gases. You know, if you don't have a transonic available, let's say, which I hope that that's going to be the ELSA meter. I hope that's a growing trend where that becomes, you know, a standard of care that a lot of people have access to. But if you don't, pay attention to your gases. Just because these patients are extremely sick, as we saw with some of the COVID patients, there's trends and then there's changes. And you're like, don't know why that changes. That should be a red flag right away. Check your cannula.
Absolutely. Agree with you 100%. Okay, so you want to go back to your slides? Thank you. Thank you for indulging me.
Yeah, of course, of course. And anyway, so you can see this is just kind of a vicious cycle, as what we were saying before we got off kind of on the critical care limitations.
Oh, before you go.
One more.
Did you read the part of the study? Listen, you got to read this study.
Yeah, we'll talk about that in detail.
Read the part about testosterone.
Yeah, we're going to talk about that.
Okay, go ahead.
I have that to talk about a little bit later. Well, let's just get to their conclusions so we can get through this article and we can really get to what we're here to talk about.
Oh, I thought that's what we were doing.
We are, but I want to include John and not just make it the Joe and Tammy show.
But then we'll have John back.
Well, he'll be back shortly.
Okay.
Okay, so this is their conclusion. And it was so good. Again, I'm just going to read it straight from the article. Obesity is a risk factor in viral pandemics, and infected patients with obesity have a worse disease prognosis. COVID-19 is no exception, and a report has just been published by the Public Health of England on the associations of excess weight with COVID-19. And during pandemic, individuals with obesity should be included as one of the clinically vulnerable groups, especially those that are morbidly obese, which is a BMI greater than 40. Clinical trials of medicinal products should emphasize the inclusion of people with obesity so that we can better understand the effects of obesity on pharmacokinetics. Further research into vaccination regimes is necessary to achieve and maintain better immune response in patients with obesity to subsequent virus exposure. Yeah. All right. So here we are.
Okay.
So we can discuss, and then I've got a lot of graphics and a few points. There's just so much information in this article that had so many things that we could talk about, but I highlighted a few that I thought would be interesting, and hopefully you guys did too.
Would you do me a favor, guys? Can you put that that conclusion back up, that conclusion slide, just for a second?
Back. There it is.
Oh, there you go. Yeah, that's good. You don't have to put it up. Oh, you can put it up. That's fine.
Okay.
Okay, you can take it down. I got what I needed. Thank you. I just got one question for you.
Okay.
About that.
Yep.
ECMO and COVID. ECMO and anything. Okay. What I saw, this latest ECMO surge, ECMO utilization surge, was a whole bunch of different things, but a lot of very obese patients. A BMI greater than 40, getting pretty big.
Yeah.
Should we be putting patients, and this may seem a little heartless, but I'm going to try to get to it as best I can. Should we be putting patients on ECMO with COVID-19 that have had delayed treatment and are now in extremis, unable to ventilate, unable to oxygenate, clearly in a lot of trouble? If their BMI, we won't say over 40, we'll say over 45 or 48 or even 50. Are we overutilizing ECMO for some of these patients because we can? And to tie that into my discussion, there's a lot of places that do open heart surgery that do not provide ECMO as an option at all.
Right.
So it doesn't even exist. We're very luxurious here in Houston. In our programs, we have ECMO everywhere and able to do it. And I think should be able to do it. But I noticed in this latest issue, the very obese patients who had delayed treatment from initial onset and then on the vent and delayed decision to go on ECMO, we had 100% failure. We had 100% mortality. It was 100%. Yeah. So tell me what's going on with that. And do you think, first question, should we put patients with a BMI greater than 45 on ECMO at all?
I don't know. I don't think there's enough data that we can say. I know our experience wasn't positive with that, but I think there were also a lot of variables going on, delayed treatment. And sometimes I think the delayed treatment was people, doctors, hospitals were trying to be respectful of limited resources, not staff, disposables, actual ECMO machines. And so I think sometimes it was hard to know when to save it for a patient that is likely to do well or use it on a patient that this is it. If we don't use it, they are absolutely going to die. And I think that was the kind of thing that they were dealing with on a regular basis. So it's really hard to be able to say we should or we shouldn't if with the patients, over, 45 or whatever the number is that you want it to be. I think it depends too on cannulation. Again, these really obese patients, femorally cannulating them is tough. And we're going to have all those problems that you talked about on top of them being extremely obese.
We had a lot of infection issues.
Yes. And then, proning. I mean, they're obese. It's going to be extremely hard to prone, but we did it on some rather large patients and successfully, but not with their femorally cannulated.
No.
I mean, so I think there's a lot of things that play into that. I'm sure John has some, if we get him back, has some opinion on that. Even if we could just get him on the phone, because he's, he's such a busy ECMO guy. I'd love to hear his thoughts on that too.
I would. Well, let's ask. What's our status, just so I know?
Oh, okay.
You're going to bring him over the phone? We have a mishap with technology again. Technology. You got to love technology, everybody.
That's right.
It's great. It's a wonderful thing to have technology. So the more we try, just wait till 2021 when I said we're going to do all this other new stuff. Probably going to just blow up, okay? But we're trying. We're going to figure it out.
We're not going to have electricity. It's going to be all of that,
Yeah, no doubt. COVID is probably going to invade the electrical grid. No question about that. But I think you brought up something that I think is very important to me. We just recently experienced this, so I think it's contemporary. The president of the United States was diagnosed. He was treated.
COVID positive.
COVID positive,
That's what we're talking about, yeah.
He was treated immediately with the 2 experimental drugs, the remdesivir and the Regeneron. He was given convalescent plasma. But from time of symptom onset to time of antiviral experimental
What,
medication.
symptom onset was Friday, correct?
I think so.
Yeah. Yeah.
So like a day,
Yeah.
2 days maybe.
Yeah, because we think he was exposed Wednesday, and then symptom onset Friday. He had immediate treatment, right?
Yes, but if you look at the incubation period, which is considered like 14 days, it's kind of odd to me that he was exposed Wednesday and then became symptomatic on Friday.
Was 2 to 10 days.
I think it's much longer than that. I think that's the flu. I think influenza's short.
Yeah.
I think according to what I remember, COVID is much longer than that.
Well, you know what? The reason I bring that up is I have been talking, just out in life in the community, and people who have been exposed, at work or whatever, no quarantine for 7 days, no symptoms, and you're free to go back to work.
Right.
But if you know when you were exposed, so. And 7 days doesn't fulfill your longer, you know what I mean, incubation period necessarily for symptoms.
But do you really know you were exposed? I mean, I guess that's the question. I'm going to look it up while you're talking to John.
I'm just curious.
I'm gonna look it up.
I think we have John.
He's got to turn his mic down.
Oh yeah.
He needs to turn his speaker off. Yeah.
Yeah.
Yeah, we understand. Yeah, we can hear you, John.
John.
Hold on a sec. But going back to the president, early antivirals from onset of symptoms. Come on.
Early antiviral.
Okay, we got it now? Thank you.
Okay.
Early onset of symptoms and treatment with antivirals. And then he went from that to the dexamethasone, the cortisone to stop his own inflammatory cascade, his own immune system response to blunt that. Which, if you remember at the very beginning, the worst thing you could do, don't give them any steroids, okay? And now it's like the exact opposite. All right. So again, we're learning as things go.
Well, this is evolving,
But patients who morbidly obese come into the hospital. They were afraid to come to the hospital because of coronamania. They had symptoms and they're hypoxic for several days, sick as could be, come in. Why are we giving those patients antivirals? Is that really what they needed to start with? And then we're going from that to the high-dose steroids. Then we're going to, of course, they're on the vent. Then their peak pressures are 40 and 50 for several days to 7 days, 8 days. And then out of desperation, because they're young, we're putting them on ECMO. And my concern is that we saw that the survivability of that was nil. It was zero. I mean, that's what it was. It just is what it is. Our experience with it. That may not be everybody's, and I respect that, but that was ours.
With those particular patients.
Yes, on those particular patients. Early intervention, early treatment, early decision to go on ECMO. We had about 60 to 65% survival, so it was very good. It was comparable to H1N1, basically in the same range. However, my point is, when you're consuming those resources on patients who fall outside of whatever guideline has to be put in place, and everyone becomes an exception, who's getting missed?
Yeah.
Who's not getting the treatment that they could have gotten? Because when you put somebody on ECMO, it is not a low resource utilizing event. It's a big deal. And so I think it's going back full circle. So let's ask John what his thoughts are.
Oh yeah. What were we talking about specifically about his? Oh, John, what is your experience, thoughts about these larger patients, the obese patients, and choosing a cannulation type for ECMO? Do we still have John?
John?
I can't hear him. I don't think we heard him.
Yeah, we can hear you.
Hi.
There you are. Hey, John.
Well, I cannot hear you guys on my phone, so I'm going to talk now.
Okay. Can you hear us now? We can hear you.
Yeah.
So, no, I cannot hear you. I don't have any sound on my phone. But if you guys can put the obesity slide back up, the one with the circles you were talking about for a bit ago.
Sure.
Yeah, so, you made some good points, but the chronic inflammation one there at the top, where obese people, or even people who are relatively moderately overweight, they live in a state of low-grade inflammatory state. And that is a very concerning thing when it comes to this disease, because one of the hallmarks of COVID has been the inflammatory, hyperinflammatory response that some people get. So we start off with a COVID-19, they go into a hyperinflammatory response, then we put them into ECMO, which is also another added inflammatory response. And then you have a patient who is modestly overweight who came to us in the first place because they live in a low-grade inflammatory state. So this is, I think, a really good talking point for one reason why, this obesity or even being modestly overweight is probably a very a big factor. I think, Tammy, on your slide where you showed it, really the largest of all the factors there that you showed. And certainly, obesity is almost never an isolated occurrence, right? You have diabetes, you have hypertension, different things. You almost always go along with it, and you have those additives. And go ahead, I'll just listen to what you guys have to say for a second.
Okay, so we're still having technical difficulties, so let's just go ahead and stop that now, okay? We can call them on the phone, on a regular phone, and see if you guys can figure that out back there. Tammy and I are going to go forward over here.
Okay, yeah.
So I want to talk more about the other things, the testosterone level, because that was a very, very fascinating to me.
Well, let me get through a couple slides and we'll get to that, if that's okay with you.
Yeah, please.
Okay, so we're going to talk a little bit about obesity, COVID-19, and what do we know? This was another article. This was an article actually referenced in the article that we reviewed, but I thought it had some things that were worth highlighting. And this is just what it was from the. It was posted on CDC, but it was a health e-stats, kind of like a little report, prevalence of overweight, obesity, and severity. So there's just the reference, but I wanted to use some of their figures. And this is just the trend of being overweight, being obese, and being severely obese in the United States. And you can see, if you look at the very top, overweight, and let's define that first off. BMI of 25 to 29.9 is considered overweight. A BMI of 30 is considered obese, and then a BMI of 40 is considered severely obese.
Can I say something real fast?
Yes.
I finally got to an overweight condition because my BMI was over 30. I finally got to 29. Finally.
That's great.
So thank you. Thank you for that.
That's great. Okay, you can see that for the most part, it's fairly consistent around the just under 40% range. There's been a little bit of dip, as we've gotten into like 2015, 2016, but fairly consistent. And for women, there's been a little bit of a spike here and there, but somewhere around 25%. It's been fairly consistent. But let's look at obesity in women. It was, in the 1960s, somewhere in the teens. And you can see it's that kind of light pink or light tan line.
Yeah, the third line down if you're looking at the left.
It is just made an incredible climb in not a very long period of time. Yeah. So that is really worth noting. Same thing with obesity in men. It was even lower, somewhere around the 10% range. And now it's just made this huge climb. And it's really, trending up with the obesity in women. Although it's still less, it's definitely trending up and looks like it could even almost overtake if it continues. It kind of cuts off there, but you can see it has a sharp incline there right at the end.
I'm really surprised by that. I really did not imagine that I would have seen this slide that overweight women numerically percentage-wise, were higher than that of men and in the severe obesity. I'm really sort of surprised by this slide.
Well, don't you think, I think some of that has to do with women's smaller stature sometimes, and so it's easier to become obese if you are shorter.
Okay.
I mean, that's just what I kind of think. I don't know. I have no data for that. That's just kind of my thoughts.
I just think it's donuts, but whatever.
I mean, I always think I should have been taller. I could have, you know, I just didn't get tall enough.
No, I know a lot of tall men who are pretty fat.
No, yeah. But, you know, like, if I was this weight but taller, it'd be even better. Okay. Severe obesity, you can see, was really almost not anything. I mean, for men, it was next to nothing. And for women, I mean, what is that, like 1 or 2%? And it has even climbed at a pretty consistent, gradual rate. And it looks like maybe it's leveling off a bit, but even at 8 or 9%, that's too much.
Yes.
That's way too much.
And that's severe. That's a BMI that is above 40.
Yes, but the minimum is 40.
Wow.
Yeah, I think we have a gnat flying around.
We
here.
do.
Okay, and I've got one more
Everybody online is gonna think
figure
I'm losing my
from
mind.
that same article, and this is a lot of numbers, but I think just generally looking at it, it's really very informative. You'll see the first 3 columns are men and women together, and then the second and third are men and then women broken out. And it's by age, by year, and the percentage of people that are obese. And let's just take, randomly 20-year-olds. A lot of 20-year-olds, you're fit, your metabolism is, revving, you don't have a lot of problems with what you eat and all those sorts of things. In the late 1980s, early 1990s, about 17% of 20 to 29-year-olds were obese. You look at how far this data goes, which was 2015 to 2016. This was, incidentally, just released in 2018. That's just as far as the data went.
Mm-hmm.
It's up to 35.7%.
Mm-hmm.
That's incredible.
Mm-hmm.
And then if you look at, as we get older, you can see in middle age, it really gets up there. We're, 42, almost 43%.
Mm-hmm.
Then if you break it down by women and men in the most recent data, women are up to 45%. That's almost, 50%. And then when you get to women 60 and over, even higher. I mean, that's just incredible to me.
How much of this, Tammy, if I can ask you, because I think you're really into nutrition, you may know the answer to this. How much of this is associated with processed foods and socioeconomic conditions?
A lot. I, in particular, just volunteer in some charities that, provide, food and things for families, not, of course, homeless families as well, but mostly the clientele is going to be people who just don't quite make it through,
The working poor.
Yeah, the working poor. They just, they just don't quite have enough to get through until the next pay period. So it's a few meals here and there. And the ones that come in and, get the groceries and the kinds of things tell us that it's cheaper to be able to go buy these, processed or fast food, McDonald's, whatever your choice may be, than to actually be able to go get these nutritious meals. And we're not talking about extravagant meals. Even if you're just talking about, spaghetti with ground beef and some pasta, to be able to do that and then also have to worry about refrigeration sometimes, all of those things play into it. So socioeconomic can be a big challenge for these people to be able to provide these nutritious meals. And if you're not eating or if you are eating these fast food types of meals all the time, there's more calories and less dense nutrition. So you're hungrier and you're getting, more calories that are going to put on the weight.
Empty calories.
Empty calories, exactly. And then the processed foods, I don't have a lot of scientific research for that, but just in my own life, I know cutting out processed foods and, everything that you're going to put in the pantry that have multiple ingredients in them that aren't just things that you recognize, they're not good for you, and they make you bloat for sure.
Mm-hmm.
So I know it is causing an inflammatory process.
Yes, exactly, because that's all leading, I think, to what John's point was, is this low-grade chronic inflammatory process that we all, that not all of us, but we have in our society. It's very common in our society, very easy to have in our society. And I know I experienced that myself in my own life, and I recognize it now. I didn't recognize it then.
Well, and even people who think they're being smart about their nutrition, maybe they're, watching their calories and, limiting their portions. Again, it's the quality of the food that you're putting in is going to have a play in how your body processes it. It's not just, that is the I guess the accepted school of thought in nutrition now is it's not calorie equals calorie. Different calories can have the same number and have completely different effects, on your body.
Absolutely.
Yeah.
Absolutely. Very good. Thank you.
Okay. All right, moving on here. Okay, so here's another article. Now, this one actually wasn't referenced in the original article that we were talking about, but it was just a short little article put out by the American Heart Association, and I thought it was a great little read. It's a couple pages long, and, it was, I think it was in their section called On My Mind, and it was a great little article, and it had an interesting graphic that I wanted to share as well. Okay, and forgive me, I forgot my glasses, so I'm going to look at the article down here so that I can talk about this a little bit. So this particular figure is talking about the pathways potentially linking obesity or what they call excess ectopic fat to severe coronavirus illnesses. And so this is more of what the first graphic that we saw that was kind of that circle around the word obesity. But this one takes it a little bit different way of talking about it, and I thought it was worth looking at. So you'll see that they start off with people of lower socioeconomic status. That's what the lower SES is. Poor diet, so this is exactly what we were talking about. Less activity, and then often race and ethnicity, and not necessarily a genetic component, but it could be cultural. It could be availability to certain things. So that all kind of links into leading up to the pathway of obesity and having excess fat. And then once you get there, then you can see that you're going to directly have lung impact, and then of course then you're going to have cardiorenal stress. And if you're going the other side down the flow chart here, you're going to have a hyperimmune system possibly, and then that goes into talking about viral load and your viral shedding. Those were all questions that they thought were worth exploring. Again, this was not a research article per se. They were just, putting together some observations and things that they have seen during this pandemic. And then if you'll look at the center portion, this is the stuff we've been talking about: lower cardiorespiratory metabolic reserve and immune hyperreactivity. You're going to have dysfunctional responses. You're going to have cardiovascular susceptibility to immune-driven vascular effects, all of these thrombotic
And that's where
effects.
the thrombotic effects are coming from, because I think this exists outside of COVID. I know we have disagreed on that. I've disagreed.
I don't disagree with you. I just don't know. I know that people have said they have seen that, but you're right. Which came first? Were you seeing it in the patients that were already obese and probably already had these problems anyway? I don't know.
Yeah, I feel like the hypercoagulability that people have reported with COVID is more associated with their underlying condition, and COVID is just creating it's revealing something more that was already there. That's what I think.
Yeah, and we talked about this earlier off screen, but let me just bring this up. In the original article that we had reviewed for Journal Club, this is just when they were discussing obesity and thrombotic risk, they referenced one article that I have not read myself, but it was done by let's see, Marietta and colleagues, and I'm just going to read you this quote. The reported incidence of VTE and COVID-19 ranges up to 8% in general wards, 35% in the ICU setting, and up to 58% in consecutive autopsies in patients in whom VTE was not suspected before death. But not suspected doesn't mean it wasn't there, I suppose. Maybe they just weren't exhibiting problems, symptoms with it. I don't know. But
It's interesting.
It is interesting.
So I mean that basically that infers, from what I understand, the VTE being venous thromboembolism. That's inferring that the normal ICU is 35%, but COVID was up to 58% of...
No, wait, hold on. These are only COVID numbers. So the reported incidence of VTE COVID-19, okay, so these are just COVID patients.
Okay.
If they were just in the general floors, it's around 8%.
Okay.
If it got as severe that they were in ICU, then it was 35%. And then in the autopsies that they did of the patients that died, 58%.
So we really do need to explore, look up at some point.
I think that'd be an interesting topic to really look at that separately.
Yeah, because VTE is a big problem in the ICU in general.
Sure.
Has been for a long time. And that's why we use those peristaltic pumps and the stockings and the various different things.
And it would be interesting to know, and I'll have to get this article and look at it myself. Do they use those type of things where they were looking at these patients? I mean, pretty much all the hospitals where we do ECMO, they have those, those booties, and they have all those different things that are really helping with that. But not all hospitals have those, I would imagine. I don't know. Is it a standard? Is it a standard of care?
Yes, that is. VTE prophylaxis is very, that is something that would normally be done in any intensive care unit.
Okay. Well, and so we're just finishing up with this figure, and then of course down at the bottom you'll see that all of these things will lead to the increased severity of COVID-19 infection.
Real quickly.
Yep. On this slide?
No, not on that slide.
Okay.
Typically, a person develops symptoms 5 days after exposure or infection with corona, with the SARS-CoV-2 specifically, but symptoms can appear as early as 2 days after infection or as late as 14 days after infection.
So it's within
and the time range can vary. So the president having potentially exposure on a Wednesday and then exhibiting symptoms on a Friday is plausible, but I think that it's unusual.
He's definitely at the short end of the range.
Yeah, the median is 4 to 5 days.
Yeah.
With a range 2 to 14.
2 to 14. Okay. All right, and here's another article that was really interesting. I mean, there's just a wealth of information out there if you were interested in this particular topic. And this one was published in Obesity Magazine, but I also, too, it's a short little read. And actually, this particular magazine does a great little summary technique where they you can read through it even if you're not very familiar with whatever it is they're talking about. And they give you bullet points of importance. What does this study add to what is already known and how this might affect your clinical practice? So it's a really, they do a great job with their articles. But what I wanted to show here is this one graphic, which is just the distribution of BMI categories in patients admitted during the study period of the intensive care COVID-19. They had an N of 124, so total number of patients that they looked at. And then they also looked at the previous year intensive care for non-COVID patients, but ones that had related severe pulmonary conditions, and that was 306. What's interesting about this is you can see that figure A, the first bar graph is the non-COVID 306, and then the second one are the COVID ones, which are 124. And you'll notice the darker the color, the greater the BMI. So the no color or the white is less than 25, so they're normal weight. then, the lightest shading is going to be considered overweight. Then sort of the medium gray or darker gray is 30 to 35 BMI. And then the dark black is greater than or equal to 35 BMI. And what it's telling us is this is showing the ones that required mechanical ventilation. So that's really interesting, especially when you look at A and then you go to B, and B is just a yes or no of whether or not, oh, I'm sorry, I misspoke. B is talking about mechanical ventilation. A is just talking about the patients that they looked at who had COVID-19 versus ones that had similar pulmonary dysfunction the previous year before COVID-19. And you'll see that COVID-19 is heavily weighed with the greater BMIs versus our typical type pulmonary infections. Then B, looking at BMI versus whether or not they were put on the vent. And you'll see that it is pretty substantial. I mean, looking at the yes on the left-hand side compared to the no on the right-hand side, yes, you still had some that were, obese that did not get mechanically ventilated, but you'll see the larger patients, the greater BMI, they had a very high precedence for that. Then looking down at C, this is just talking about the percentages of, depending on BMI, who got mechanically ventilated. And you'll see the patients that are at the greatest BMI, almost 86%.
Mm-hmm.
That's pretty substantial. What do you think about
It is. I think it's very high.
Yeah.
I think that patients who were, low BMI, under 25, 47.1% of them still had to be mechanically ventilated. Tells me that, this is, it's SARS-CoV-2. I think it is a very severe.
It's very severe.
Acute respiratory distress syndrome.
Yes, very severe. This particular study, if you don't mind, I'm going to read you just something real quick. It's their summary of how these results that they found could change clinical practice, and I thought this was worth saying, that, again, patients who are obese should avoid COVID-19 contamination, and all preventive measures during the current pandemic. That's, again, someone else saying these are a vulnerable population, just like we were focusing on older or immunocompromised. I think it needs to be stated that obesity in itself is its own vulnerable population.
Absolutely.
Yeah.
And maybe we need to do something about the obesity epidemic.
We're going to get to that too.
Okay.
All right. Moving on here. Okay, and one more article, if you don't mind. This one was, let's see, this is actually a quite lengthy article, and it was really informative, but it's basically a global perspective on the epidemiology and biological relationships of obesity and COVID-19 thus far. It was published in late July, so I think it's data collected through like June, and it was had some really interesting information, but this is what I wanted you to take away from it. Okay, so if you look at the top of the graphic in A, 1990s, the time range, that's a world map, and you'll look at the key in the middle of overweight and obesity prevalence or persistence, yellow being, less than 50% and going on up there. Just look at the change from the 1990s to 2010.
Yep.
It's quite incredible. Developed worlds are just astronomically moving forward with, I guess, availability of convenience foods and, less laborious work that has to be done. And we have a real pandemic itself just in obesity.
Clearly, yes, that
Yes.
is a global, I agree with you, that this is a global problem as the world becomes wealthier. And I think that our Department of Health and Human Services needs to do something.
I think it needs to be a focus. I do not think it's a focus enough. I think recently in the last 20 years or so, just since when I had a child, that they're really, pediatricians I hear are, asking about activity of my child and all of the things, even before there's any kind of concern for overweight children and obese children, which is a real problem. They're already, talking to you about making sure they're getting that activity and everything. But I think you'll notice if you have school-age children that it's less and less movement that children are getting in school. So it's really things that have to be done outside of school. We've just jam-packed all the academic things that we think these, especially young children, need, that they're not even necessarily getting to move around each day.
Yeah, we have an inactive society.
We really do.
I mean, all of this nonsense of working from home and all of these kinds of things, and I think that I'm not really trying to make this a political discussion, but I will say this. I think that and I've heard people say it, I'm, again, not being political, I'm just making a statement that I would have on my own merit. I said this, in fact, I've said this to you before. I believe that when this is all said and done, the number of fatalities that had absolutely nothing to do with this respiratory virus, vis-a-vis alcoholism, heart attacks, possibly ruptured aneurysms, bowel obstructions or bowel perforations or whatever it may be, pick whatever you want, cancer, etc., that the fatalities that occurred during our hypervigilance of stay at home, 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 don't go out, isolate yourself, and protect yourself from the horrors of SARS-CoV-2 are going to be higher than the mortalities that were directly a result of being infected with the virus.
Which are, according to Johns Hopkins data that was published most recently, which I think is
How did you know that was going to be my question?
I just knew I was going to need this data. About 1 million deaths worldwide, 35 million positive infections worldwide, about a little over 7 million in U.S. with about 210,000 deaths.
Right.
So
that's on the SARS-CoV-2.
Yeah.
But what is the actual mortality that is related to patients not seeking care?
No, I don't have that.
Or economic destruction and alcoholism.
Well,
and
it's not just that.
Drug abuse,
right,
and suicide,
right,
blah,
suicide,
blah, blah.
And all kinds of domestic abuses and depression, or even looking at non-medical things, just looking at how the education system, wasn't prepared for what they had to do, and likely still aren't quite prepared with. I'm sure everyone's done the best they can with making adaptations and online learning and all these things, but if you're not used to doing those things, there's challenges, and I think that it's going to be lasting impact, even just in the educational realm of the children. They're behind.
Not just that, we have a colleague, I won't say their name, but a close colleague whose online education program school was so exciting that he swallowed 6 magnets and had to be, airlifted to Texas Children's Hospital to be managed. And I don't know if we know the final outcome of this yet. Last I heard, he had not had to have surgery. But, I know that could happen at any time.
Sure.
But I think that, how does it go? Idle hands are devil's work. How does that saying go?
Idle hands are the devil's toys, or
something like that. Or idle minds are the devil's playground. Whatever it is.
Whatever it is.
I'm
yeah.
fixing to do a Joe Biden here and not know what the hell I'm really trying to say. But you know what I'm trying to say. Okay, nothing personal.
Unnecessary.
I'm not trying to be political. Okay, take it back. All right, I withdraw the comment. Okay.
But yeah, the point is that there's lasting effects, lots of lasting health effects, lots of lasting social effects from this. And I think that we're not going to really fully understand them for some time.
Yes, but I think we're going to eventually fully understand them, and I think that it's going to be very unsettling.
Sure.
I already feel it's unsettling to me.
I agree.
Go ahead, I'm sorry. But that's an amazing chart.
Yeah, this chart is just, it's great.
How many McDonald's per capita are in the ones that are there?
That would be extremely interesting overlay that I could have done. I should have thought of that.
You know what? I'm going to try to look that up. That's something I'm going to do.
You really should. But yeah, this article is worth checking out if you do have an interest in this. It was published in Obesity Reviews. It was under their public health section, and it's lengthy. I mean, I think it's like maybe 25 pages or so, but it's a good read. It's not too complicated, even if this isn't your specialty, but it was a really interesting read.
Well, I think this obesity issue is a hugely important issue for perfusion.
Sure.
You know, I mean, when we have to manage these patients either in the operating room during full cardiopulmonary bypass, or we're managing these patients in the ICU, understanding this interplay of obesity and all of the other organ system derangements that are secondary
beyond
to it.
just this is a big patient, we're going to have to move from the bed here to there.
I mean, we call it cardio, right? There's cardiorenal system, right? We're familiar with that. There's hepatorenal syndrome, we call it that. But I think that there's an obesity, cardio, endocrine, you know, renal, hepatic. There's a inflammatory interplay relationship, a syndrome that occurs. I think obesity on its own is so influential in affecting all of these other individual physiologic components and anatomical components, vis-a-vis lung volume, diaphragmatic weakness, all of these other things, pressure, intrathoracic pressures, all these things play such an enormous role. And I think that I always say the kidney is the most underappreciated organ in our bodies.
If John was here, he would
agree with me. Yes, he would be. He's applauding right now. I know he is. But I think obesity is much in the same way. We're underappreciating what it's actually doing in so many different aspects.
Part of that, I think, has to do with that it is a disease state that for a long time...
Acquired disease state.
For most people. It's an acquired disease state. But it's much like, you know, alcoholism or drug addiction or depression. It's one of those that people don't like to talk about. They don't want to address it. They often just put blame on the individual instead of looking at, doesn't really matter how they got there, and we need to look at the disease process that's going on and what we can do to improve that. We don't take other diseases and say, whatever it is, and I'm not going to I'm not going to take it seriously. I'm not going to look at it as a serious illness because I think it's your fault that you got it. That used to be how people thought, but you know, that was hundreds of years ago.
No, I don't think that's true. I think I still feel the same damn way. You got diabetes. What do you think you're going to have if that's what you're going to do to yourself?
Well,
I mean, I think I still think that
everyone
way,
has to
frankly.
people have to take personal responsibility
That's
for
the
their
problem.
own health.
We don't.
But
We've all become victims.
But I'm not talking about playing victim mentality, but I'm saying as medical professionals, we need to look at this like a disease, like any other
Fair
disease.
enough. That's true.
Right.
I agree with that.
I mean,
100%.
but everyone has to take personal responsibility for their health, even if it's, you know, forget obesity, but let's talk about, you know, I don't know, skin cancer. You know, like you're out in the sun a lot, you have a higher chance of getting skin cancer. You need to take personal responsibility to protect yourself. It's the same kind of thing with, you know, any disease that we know there are precautions that you can do to limit your...
You're so much more compassionate than me. So with that said, do you not also think that our interpretation, our visual interpretation of obesity, what obesity really is, has not changed dramatically over the years? That we look at people now that 30 or 40 years ago we would have considered, oh my God, that person is really fat, where we now go, yeah, they're a little overweight.
Oh, yeah.
Have we not done that?
No, completely.
Our sensitivity to it?
Well, like anything, the more you're exposed to it, it's harder to be shocked by it, if you will.
Mm-hmm.
So, I mean, just look at and this is a little bit sensitive subject. I don't mean it to be offensive to anyone, but just look at the availability of clothing. Used to, if you weren't these certain sizes, clothing was difficult to find. And I think clothing should be available for everyone. That's not what I'm saying. But what I'm saying is it's now commonplace to be able to find all range of sizes everywhere, in all stores.
Yes.
And
you no longer have to go to the big person store.
Exactly. That's my whole point. And that's not a bad thing, but it does show the desensitization to that issue.
Mm-hmm.
And, you know, again, I think we should be inclusive of everyone, but I think as a society, we do need to look at, although people don't need to be all shapes and sizes, there are healthy sizes that we should all strive to be.
Mm-hmm. That's another program. I agree with you 100%. That's another program, though, that we need to do. We did it once before. Alarm desensitization in the ICU.
Yes.
Mm-hmm.
Yeah.
Because we live around it all the time.
Mm-hmm.
I hear those bells going off all of the time. And it's funny because it's, you know, we say it's desensitization, but I've seen nurses ignore like every single alarm, but they pick up the one that really mattered.
Yeah.
And somehow they're tuned into it. It's, you know, I've always been fascinated with how they do that.
It's like having children. Haven't you ever had your child's making a lot of noise? Even they could even be fussing, you know, in the back seat, and they're bickering in it. But as soon as you hear something that sounds a little different, you know it's serious, and you tune right into that.
Mm-hmm.
Yeah. Yeah. I think it's very similar.
I kept mine chained. So I never had that problem.
Okay, let me just get through this. This is one of the last things here. And this one, again, is just another way of looking at, you know, the complications that come along when you have obesity along with COVID-19, what has been observed, what has been recorded. You know, metabolic dysfunction is huge. The immune impairments, you know, the whole dysfunction in the immune system. And then the inflammation, you know, those are all going to lead to comorbidities. The comorbidities are going to give you those things. You're going to have physical things that are, you know, sleep apnea. Huge information out there about sleep apnea and that being a predictor for other severity within this disease. And then, of course, the clinical manifestations of all these problems. You know, you have increased hospitalization, more of these people going to the ICU, the mortality rate's higher, you know, more ARDS. And then talking about, again, the vaccination. We don't know, you know, how when we get a vaccination, because these things typically aren't geared towards people that are this large, and it's not well understood with that much fat, what's absorbed, what's cleared. How do they have the same kind of antibody production to these things? Those are all things that are unknown, and with a disease that so heavily affects obese people, they really need to be a part of the research studies that are going on so that we know how it affects all ranges of people. Because we've already established that, 40% of the United States is obese. It's almost half of us.
That's amazing. Well, I'm not obese anymore. I'm overweight.
I'm so glad.
I'm happy with that.
I'm so glad. And that's it.
Okay, the one thing that I wanted to really talk about.
No, we're getting to it.
Good.
It's just kind of an offshoot. I didn't have a lot of information about it, but I highlighted a few things, and that was one of them.
Yeah, that testosterone really caught my attention.
Yeah, okay, so let's get to that. So this, what you were so interested in, this kind of fell under our original article's focus when they were talking about obesity and the endocrine system. And here's something that just really hit home to me, which I think we all know, but just thinking about it like this, that, you know, adipose tissue is an active organ. It is an organ in itself and how it's going to behave, how it's going to have important physiological functions that are mediated through hormones. And obesity is associated with several endocrine alterations. So one of the things that they looked at under this big topic is obesity and testosterone. as we know, testosterone concentrations in older men goes down. But what they also found was testosterone concentrations in severe obesity is not age dependent. So it plays an important role in that. Therefore, they had the hypothesis that low testosterone in aging men with obesity may have played a role in the cytokine storm and the severity of the infection, which I think is really interesting. And then they talk about, further testing might be needed or is definitely needed, and for further hypothesis about, maybe testosterone treatment for that particular vulnerable group. That.
Well, it's funny because I've actually I have, if I may, if I can actually act like I have, some intellect, some academic intellect. I've wondered for 30 plus years whether or not testosterone therapy for its anabolic qualities should not be something considered for patients who are in the ICU for a variety of different issues. But in particular, I was thinking about it for frail-ish heart surgery patients. And just, I understand that, it increases your red cell mass, so you do produce more red blood cells. It increases your muscle mass. It increases, that's why those weightlifters use it, right?
Sure.
To build up stuff like that. They're excessive, though. Obviously. But it does that, so it increases your. So now I think it also increases your coagulability. I think it does make you a little more hypercoagulable, but I think that can be managed with appropriate anticoagulation therapy. But increasing red cell mass, increasing muscle recovery time when you're trying to walk
that would
these
definitely
patients.
Address the frailty issue.
Yes, and I think, or just weak. They're just weak from whatever situation they may have had. And in women, their testosterone level is naturally going to be lower than men's. So maybe, a more appropriate dosing for them. But I've always wondered if that was not a good option for treating patients in the ICU for a variety of reasons. I think it's so critically important. And if all of these patients who are obese have COVID, and it does have an effect on their immune system tremendously. Sure. All of this, again, all of our physiology is so interrelated, and I don't think we know so much, but medical knowledge is doubling every 72 days at this point in time. What we understand doubles every 72 days. And so, I think we still really barely know. It's like pi. You just keep running that number out because it can't ever get to the end, right?
Okay, I had pie over the weekend. I thought you meant it's like all the kinds of pie.
No. I meant,
it's endless.
No, I meant the other pie. That was great. So I think that I
really do love pie.
I understand.
Both pies.
Yeah, I love pie too, but they can't.
All pies
but
and
they can't
the
solve,
pie.
They can't solve for pie,
No,
right?
Right.
So I think the same thing is going to be with understanding human physiology. I think that there is I think that we are not even close to truly understanding it. And so with as much information as we have, I think that, I don't know, I've had this hypothesis for a very long time, but I've never seen it actually used.
Well, I think it's very
in critical care medicine.
Yeah, I think it's very interesting. I think a lot of points I read in here were very interesting, things I hadn't thought about. The testosterone, also like the micronutrients, just talking about that, let's see, a large body of data showed that vitamins, including A, B6, B12, C, D, E, and a number of other things. But most importantly, they saw that vitamin D deficiency in particular might be a potential contributor to susceptibility to COVID-19.
Well, you know what? That's what Dr. Matoyer says. Dr. Matoyer says A, B, C, D, E, and Z.
Yeah.
So you got your zinc. So that's what he says you should be doing. So A, B, B6 and B12, A, B, C, D, E, and zinc. And as a preventative.
Yeah. Make sure your levels are good with all those things to hopefully help you not get it, or maybe
develop your own antibodies.
Yeah, exactly.
Fast enough to control it.
And I think also they were talking about decreasing the severity and symptoms. So just generally speaking, maybe you get it and you don't even know it, it's gone.
Right, you get it, your body deals with it, you develop your antibodies, and boom, then you're gone. You're seroconverted, and you have got your memory cells. So any re-exposure, you're going to be able to deal with it even better. But I think that all goes to obesity, healthy diet.
Sure.
We're just going to go round and round and round in circles with this thing.
And I think we might be running long on time here, but I wanted to get this out there before everything gets too far away and I don't get to say it.
We have short programs once in a while. If we go
So
a
it's
little
okay?
over, it's
All right.
okay.
Sorry. This topic was just so interesting. The last little section they had in this article, and I thought it was worth talking about, which we all know there's benefits to weight loss.
Yes.
But what is interesting that I think people overlook is, especially for these morbidly obese patients, or even just obese patients, but patients that have a lot of weight to lose. Even, sure, have bariatric surgery, do all those things. It's wonderful for you, and you'll see lots of improvement. But even short-term small amounts of weight can change your metabolic dysfunction in these patients. And it's not just for COVID, it's for everything, obviously. But even just small changes, if bariatric surgery is not possible for you, whatever the reasons may be, these small changes, just like with smoking. You may have smoked your whole life, but even in, a few months, a year, you are seeing benefits from that. So even these small changes, it doesn't have to be something, some great big thing that might feel very hard to overcome. If you have 100, 200 pounds to lose, that's a lot. And it can be very overwhelming if you don't have the medical support, you don't have the social support, all of those things. But small changes can make a big difference. So,
Absolutely agree with you. Well, I thought this was a excellent program. I mean, this was, I think, by far the best Tammy Sparacino Journal Club we've done, and I want to thank you and compliment you on an incredible job.
Oh, thank you.
This was a great article, and then series of articles that you also explored, and I know how much work goes into this. So I appreciate
really
it.
interesting.
I appreciate it. I believe our audience appreciates it as well. I want to remind you, our next program is scheduled for Thursday, October 22nd. It will be at 5 p.m. to accommodate more of the United States, or this region, South America, Central America, Canada, and so forth, our Canadian colleagues. I want to remind everyone again, please go see get our app. If you want, I don't know if you can throw that up again or not, the QR code, but if you don't, just go to the beginning. If you can't do it, don't worry about it. But you can go on Google Play. You can go on.
Tell them the name of it.
It is the Critical Care and Perfusion app.
Yeah.
Is what it's called. And you can find it on here. I'll show it to you here. So there it is right there.
They've got it up too.
Oh, you have it up?
Yeah, they have it up.
You can go to MediWeb, click on, what's the menu tab that it says, David? Okay, so you just click on the menu tab, Critical Care app, and you can use your QR code, or you can just click it from there if you're on your phone, and you can download it. As I said, it's $2.99. Nurses in the ICU would love this as well because it has an IV calculator. Now, there's also an individual app that is just an IV dosage and rate calculator, but in this particular app, the bigger app, has everything plus that. So critical care nurses would, I think, truly love this app. So please do me a favor, if you would, show it to people. Download it yourself, see if you like it. Give us one of those ratings. That's really important to us. And look, this is how I'm funding my retirement. So I really need people to buy it. So buy several, get several devices and put it on every single one. And look for updates, because we will be updating it as we continue to get feedback and it gets used to make it even better and let it evolve with our profession. So I want to thank everybody for their time today and for joining us. We always appreciate your comments. Don't forget about our sponsors, which I talked about, LivaNova and Siemens. Even though Transonic is not a sponsor of ours, I think that it is a company that is doing an incredible job at trying to contribute positively to ECMO as a therapeutic modality. Of course, we're perfusionists and we do more than just ECMO, but I think sometimes this in the current state of affairs, I think ECMO has just become such a big, huge topic.
Well, I think too, it's become,
we talk about it a lot.
It's become more prevalent where it used to be only in certain centers. We are seeing it expand, and so I think people have a growing interest in developing those programs.
Absolutely, but we want to do something fun too. I do have to say this one last thing. So we're going to be scheduling a program in November. I think it was November, right? Or December. November. We're going to be doing a program in November with Dr. Devinder Bhatia. Now, if you remember Dr. Bhatia, he was Eddie on the Munsters, so you'll be able to remember him from that.
Now.
And with that said, he considers himself somewhat of a wine sophisticate, if you will. So he's going to do a lecture on the history of wine as a medicine, and then we're going to, for those who purchase the program, or for our members who want to watch it that are unlimited plan members, we will send you the wines. And for those who just want to watch it, to enjoy it, you have to register for it, but you will, we'll give you the list of what you need to buy, right? And so you buy the wine, and he's going to teach how you properly, grade wine, how you properly taste wine, the differences between reds, of course, and whites, and all that kind of stuff. And then we're going to test his abilities to be able to actually tell us which wine is a high end, which wine is a sort of a normal person's, like what I would buy, and then which one is some cheap wine. And then there's one more, and we're going to see if he can put them in order and then tell us what the fourth wine is associated to, which one it came from. So we're going to do something to it that he's not going to know. And so he'll never watch this, so I'm not really concerned about him hearing this. But we're going to see if we can really throw him off and have some fun with him.
It's going to be a lot of fun. It's
going to be a lot of fun. I also want to talk to you very quickly about our special program that's going to be coming up, and it is actually scheduled for a special series that we're doing with Humanetics. The first one is Tuesday, October 13th, 11 a.m. to 12, and then we're doing the same program, but both are live, both are organic, if you will, at 5 to 8.
But it's the same material?
The same material, okay. Yes. The same faculty, the same material, and it's going to start at 11 o'clock to 12 o'clock, and it's going to be on clinical and financial benefits of autotransfusion. The morning program will also have a faculty, which we need to add to this if we could, guys, from a European anesthesiologist. And him and Dr. Samir are going to be talking about clinical and financial benefits of autotransfusion. And then for our U.S. audience, we're going to do the same program, but both are live. Both are same data, same information.
The afternoon and the evening edition.
Yes, correct.
Okay.
So I don't want people to think that it's just recorded. We're not going to just show a recording. It's going to be 2 live programs on the same thing with the same faculty from 5 to 6 for our U.S. audience. There is a required special registration for it. But again, if you're an unlimited plan person, you can participate in this. It is approved for 2.4 Category 1 CEU by the ABCP, and would really like everyone to make sure that they go to this. I think we sent us a notice out here just recently. So make sure you check your email and subscribe. Of course, subscribe to our channel. You'll get all this information, okay? Very important to do that. Become a member of perfusioneducation.com as well. It's free. You only pay if you want the CEU certificate. So it's free to join. We really want you to join. We appreciate you for doing that. With that said, I think I've told everybody everything that I could possibly tell them. But go on perfweb.us and check out the schedule. Click Special Series Schedule 2020. You want to make sure you take a look at that, because they're real easy CEUs to get. and we all need them. I mean, that's just a reality, and they're category 1.
And we're fun.
And yeah, this is a great show. I appreciate. Listen, I love doing this program. I do, and you are incredibly good at it yourself. So you have been a real joy to work with, and I've really truly enjoyed it a lot.
Yeah,
we got a good thing going here.
We
sorry we missed John.
Yeah, we missed you,
John is a wealth of information. John, we are sorry we missed you. I don't know what the technical issues were, but hopefully we'll get those worked out for the next time. And in the meantime, good luck. Keep your reservoir full, and keep the flow up and the pressure and all the other things that we do. Be safe, and we'll talk to you next program. Take care.
Bye-bye.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient populations.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.